This question and answer session is really around getting just, if you have any unanswered questions about the presentations, if that doctor is here, and just general questions, understanding what you can do and what you're going through, et cetera. So let me gather the doctors. I hope I didn't lose them all.
Yeah. I got to hear your talk, which was very good. Thank you.
Both, I guess, would be good if you felt. Okay. All right. All right. Welcome back from our short break. Keep in mind that lunch will be coming up at 1. What time is lunch? 1. 1, yeah, sorry, we're a little off schedule, but I always like to keep food in the back of my mind because it motivates me. The doctors on the panel here, you've met them all during their presentations. Nadia, who's over here, works for the foundation, as does Katie, and they will be coming around with mics. So simply raise your hands. We're going to ask that whoever has questions, ask at least one question, and then let's get around the room, and then we can come back for multiple questions.
Not at least.
Oh yeah, just one, apparently. It's been a very long day. Okay, great. So, doctors, is there any, well, I'll just start with the questions. Can we start with questions? Yes, ma'am.
Yes. This is to Dr. Royal. I have neurosarcoidosis. I've been diagnosed since 1984 with lung. And my question is, I'm not on any medications right now, and I was diagnosed with the neuro in 2010, and I just, don't listen to me everybody, I tapered myself off with a prednisone. Tried the medications that you all listed, Imuran, Self-Set, methotrexate, Plaquenil, and all those give me side effects. So my question is, once it affects your brain, I've noticed I have a Remicade every 6 weeks because it's in my muscles, it's in my bones. My question is this, does that ever go into remission?
Well, I think that earlier somebody during their talk showed what sort of manifestations are less likely to remit on their own. Nervous system sarcoidosis usually doesn't. So you've been on Remicade all along?
I've been on it since 2012.
Okay.
Remicade.
So after the neuro showed up, you got onto Remicade?
Right.
Okay. Well, that's a good idea.
Right. But I want to know, because I'm just not understanding how to go to the lungs.
Right.
Go to the brain, but it's a long period.
Yeah.
To transfer. So am I probably a candidate for this going to affect every organ in my body eventually, or?
Well, the reason why I said it's a good thing that you're on the Remicade is because now you have a chance to control it. And with some of those other medicines causing side effects, it can be very difficult. Sometimes you can give medicines to control certain side effects. But our experience with other neurological diseases is that there can be a tendency to put off going on treatment and being aggressive when you know that a certain part of the body is involved. Eventually things tend to catch up, and it can be very difficult to turn the clock back. So the fact that you have it there doesn't mean that it's not going to get any better. It's unlikely to disappear on its own, but it's a good idea to control it and try to get it to improve, so that 20 years from now, you're feeling a lot better than what you would be if you weren't on the drug. Does that answer your question at all?
Yes.
Yeah. Well, the other thing is that you have to wonder if your time off the medication actually allowed. It's hard to know exactly where the disease is. And we do see where, I'll give you an example. about 10 years ago, insurance coverage changed for a lot of people in the Baltimore area. And it got to the point where some people just couldn't get the medications they needed for their conditions right away, and a few people with sarcoidosis ended up being without their drugs, just as among those who weren't able to get their medicine. So it was very odd. Some people who had pulmonary sarcoidosis, all of a sudden we had this explosion of what we call sarcoid neuropathy. We hardly ever see it. And it's probably because, people weren't on the medicine long enough for some manifestations to develop and to progress. So, and we tell people with MS all the time, when you know you have it, go ahead and take the medication to try to restrict it and to try to keep things under control.
Yeah.
I understand.
So what I do is I just taper myself off so many months, and then once I do that, I start attacking my muscles.
Hopefully we can get some good information with Actar, and it takes working very closely with your physician trying to look at other options and complications.
Thank you.
Yeah.
Thank you. Okay, next question.
Okay, I guess that's probably why you guys are doing the research. Because I'm dealing with the sarcoid. It started long before I found out it was in my lungs. However, over the past 2 years, I wound up having carpal and cubital tunnel surgery. And I lost the physical nerve that's in my hand going up to my chest. It's actually small, so the muscle that belongs between my hands on both hands are gone. And so they told me to hurry up and have surgery. I was going to lose the use of my hands. So at 43, I got hands that shake trying to use an iPad. However, my question is, I've been diagnosed with that. I've been diagnosed with, they call it the suicide disease. It's called trigeminal neuralgia. And I thought it was something besides the sarcoid. I was listening at it, he was saying that a great imitator. So I'm on gabapentin to try to help with the sudden nerve pains that I have in my face. Feel like electrical shocks or like a bee stinging me, and it'll hit. I thought bees were stinging me before, and I got black spots and everything. The question I'm having is with the neuropathy, does it also ride along with the rheumatoid system as well to I guess, affect everything in your body?
Well, when it comes to the nerves being involved in sarcoidosis, we don't necessarily expect the same medication that you were on controlling the pulmonary complication to be enough to cover what's happening with the nerves. Generally, one would expect that if you go from just having the lungs involved to something else, even if it's not the nervous system, then it would suggest that the coverage that you have needs to be stepped up to the next level, because it's been able to allow, there's a good chance that there was some activity there already that was kept under control. Maybe some brand new activity appeared, it's hard to know, but it sounds like, and that's where we're starting to see the anti-TNFs work in people with nervous system involvement who didn't respond to these other drugs.
Thank you. Next question.
Hi, Dion? Yes. I have neurosarcoidosis too, and they tell me it's in remission now, so I guess it's not hopeless. But my question is, I have it in my lower back. The pain is in my leg. I haven't got complete feeling in my lower leg, and I'm continually on medication for pain. Is there anything that can be done, or is there any hope for that to go away? Will that always be with me?
So is the pain from the neurosarcoidosis?
Apparently, yes.
Okay, so it's from a nerve being involved. You know, when it comes to a lot of neurological diseases, damage can occur from whatever the disease is, and even if the disease clears out itself, that damage is still there. So obviously we would call that a symptom that has to be controlled. So it's just like if you have arthritis and you have to take a leave or something like that to control the pain. Assuming that, as you said, well, you did say your sarcoidosis is in remission, so theoretically the disease is not actively causing your pain, but whatever damage was done, you can imagine that if you cut a nerve, even if the knife is gone, but the damage is still there. So in your case, it sounds to me like controlling your symptoms, and there are ways to control pain. It's not always easy, and sometimes one has to be referred to a pain specialist, especially when it comes to pain that radiates down the leg from nerve involvement.
What are the chances that it'll recur? Do you have any?
Of the sarcoidosis?
Yeah.
I don't think we know. One has to do studies, and one has to do studies looking specifically at nerve involvement to know what the recurrence. Those studies are certainly much better done when it comes to pulmonary sarcoidosis and cutaneous sarcoidosis. But, you know, a disease like sarcoid is a lifelong disease. And I think that, you know, I assume when it comes to diseases like that, especially if there has been a certain organ involved, that one just has to be prepared for any return and to move quickly to treat it.
I have one quick comment, and I would like to back it up what you just mentioned. Once you have other organ involved in addition to pulmonary, you know, I told you that you have to be very conservative in treating with the lower doses of steroids for pulmonary sarcoidosis, like 20 milligrams and downwards. But once you have heart and cardiac sarcoidosis, you need to increase the dose of steroids and think about adding another one or two medications, steroid sparing agents like methotrexate, azathioprine, hydroxychloroquine. That's one. Second comment I have is we need to be aware some of main disease may be caused by sarcoid, but ultimately some of the symptoms need different treatment, and we need to tailor for the particular organ involvement. Like I told you, if you have irregular heart rhythm, you need the implantation of defibrillator, or if you have heart blocks, you need pacemaker. So if you have back pain, you may need different medication. If you have trigeminal neuralgia needs to be taken care of as an independent condition at that time. Okay? Sure.
I think I already know the answer to this, but you have been referred to physical rehabilitation, right? Yeah.
Okay, next question.
Hi. I was officially diagnosed in February 2014 with sarcoidosis. Although I feel like I think I've had it for many years before that. And I had MRI, several scans done, and they've seen lesions on them. And they've tested me for MS, and that was never positive. But I'm wondering, you know, if I do have it, is there any difference in regards of treatment? I mean, I just heard you speaking that, yeah, you should treat that organ, but when I spoke to this to my rheumatologist, he just kind of, you know, well, you have it. And the only way to know for sure you have it is to have a biopsy of your brain. So I just want to know, you know, is there a different type of drug? And, or else, how else could, you know, I be diagnosed? And I guess you kind of answered my question is, can it be stopped or slowed?
Well, it can be treated.
I meant to say, I've tried methotrexate, then for like 6 months, and then Humira for 6 months, and now I've just had my third infusion of Remicade.
So when I treat someone with neurosarcoidosis, I do so under the assumption that it can be stopped. And we do have patients who we put into remission, who go into remission, I should say. And some patients need more aggressive therapy than others, and some have to go on combinations of medication. It can be very difficult to tell neurosarcoid from MS. Sarcoidosis is a great mimicker. It can look like multiple sclerosis. It can look like stroke because it can affect the brain itself. It can affect the blood vessels. It can affect the meninges. It's something we call chronic meningitis. It can do that. It can do it all.
I've had meningitis in the past.
Yeah. So, the issue came up related to Tnfalpha inhibitors in sarcoidosis. And, it is an observation that there's some people, you give them a TNF alpha inhibitor and they develop brain inflammation for the very first time. We see patients develop MS for the first time after starting those medications. And there's some MS drugs that'll make sarcoidosis worse. I've treated sarcoidosis for years, but one reason why we started this study is because it is such an imitator that we want to be sure that we can treat this disease, and also we want to be sure that some of our MS patients, we don't end up treating MS or sarcoidosis thinking it's MS. There's a fellow who somebody showed a slide earlier today, Dr. Ansis showed a slide earlier today with data from a person in Pennsylvania, a neurologist in Pennsylvania named Tom Scott, who did a study, and what he showed was that, and he's got a strong interest in sarcoidosis, and what he showed was that in any of his MS patients, at any point along the way, if he saw any signal to suggest that they had sarcoidosis, sooner or later, they developed clear sarcoidosis. It may take 10 years, may take 15 years. So it's a great mimicker. And the question was asked earlier, why do these drugs cause people to develop the disease when you're trying to treat it? Well, MS had an experience with that. So there's
Yes, sir.
there's this disease that's studied in animals as a model of MS called EAE. You give those animals a TNF-alpha inhibitor, it shuts down their experimental disease. So with that information, a clinical trial was done in MS, and the TNF-alpha inhibitor made everybody with MS worse. And it turns out, people aren't mice. That's the first, as you can imagine, the first reason why that happened. The other thing is that, there's a balance that the immune system follows, so that, they call MS and sarcoidosis a Th1 disease. Well, there's a little Th2 in there, and it turns out that if you make, sometimes you can treat the Th2 so well that more Th2 appears. So, you get this shifting of the balance around. And in your case, with some of these things that are going on with you, I'm not so sure I'd push the TNF-alpha inhibitor so much, but I don't know your case, so I have to be careful.
Right, I understand.
I have a few questions for you. Do you have any involvement of the lungs at all?
Yes.
Okay, they know that.
That was,
Biopsied?
pardon me, yes, it was done through a mediastinoscopy.
Okay, so you have a biopsy-proven sarcoid.
Yes,
then, okay.
yes. And I had these issues, headaches and stuff, and that's how I came about having MRIs, and then they saw those lesions, and lately I've been getting like extremely severe headaches, and I don't know, if it's tied in. That's kind of what I wanted to know, if you knew.
Thank you.
Okay, thanks.
Next
Come
question.
down to the next one here.
Hello, my name is Kathy. Living in Northern Illinois. I got diagnosed in 2010 pulmonary, 2 times on Pred, the lovely prednisone. Now I'm off Pred, so I did a PET, and I got a Christmas tree with the PET. So they say it's in my bone marrow. Thanks a lot. Go to a neuro, tells me he wants to do a spinal tap, do this, do that. I'm really tired of the tests, quite honestly. In fact, I told him no more. I guess what I want to know is there a National Physician's Guide that would help my PCP? Because I'm basically doing my own clinic, going from doctor to doctor. And so what I've done is I talked to Dr. Royal about it a little bit, but I just made a lovely guide of myself. So when I go to a different doctor, I can show that doctor, and actually some doctors like that because visually you can look at that and say, okay, that's great. Now you got one pupil bigger than the other, and your hearing is gone, your heart, whatever, you know. But it's right there, so that may help you all with that.
I
And
think I
besides,
can-
I'm a teacher, but is there a national guide, or is anybody working on a national guide? That's number one. And number
Yeah.
two for me, since I don't really want to take the lovely prednisone anymore, because I think it's poison. But should I go from that to methotrexate to then Remicade, or what?
I can answer the first one, Kate. There is a treatment protocol that was developed by our scientific advisory board, by FSR's scientific advisory board, and it's available to download via our website. It's available also on a mobile app so that you could bring it into your doctor's office, and it really it was just updated in 2014. Again, you know, it's as evidence-based as it can be, but it's you know, it will guide your doctor on those questions, and I really encourage you to get that and to bring it in, even if your doctor doesn't want to look at it, because it does help you become part of that answer. It's called the treatment protocol.
It's on the FSR website.
It is. Thank you. It's on our FSR website. And again, once you get to it, you can just print it. Or if you don't want to do that, it can go to your phone or however you want to do it. And then we can always mail it to you too if it's just not something that you know you don't have capability of getting. As for your other question, I'm going to hand off to the doctor.
Okay. I want to tell you that since you already had a PET scan, it's worth repeating the PET scan to see your disease activity. So one of the things that determines the treatment duration and the type of medications we use is, first we need to determine how active is your disease. So if your disease is active and you still have a lot of metabolic activity that lighting up like Christmas tree, that means your disease is active. So you can be put on a combination of a low dose steroids if you don't like it, prednisone, or you can be treated with methotrexate, hydroxychloroquine, or even Remicade infusion if you still have very active disease. So that needs to be determined.
Thank you so much.
Can I
We'll be happy to see you, but that's what.
Yep.
Yeah.
So can I say something to the
Yes,
first
ma'am.
question? The first question, that algorithm is a beautiful algorithm, the treatment algorithm that's on the FSR website, and it was designed specifically to be a reference to assist physicians who don't see sarcoid day in and day out, who don't read the sarcoid literature day in and day out. I would step out on a limb to suggest I will just put it in my terms, that if my patient wants me to read something, or if my patient goes to get a second opinion on something, I think that's only a wonderful thing. And I think we should all have doctors who feel the same way. So then I would ask you to reflect on your physician experience if you're not having that experience. And then secondly, can I respond to the methotrexate question? So I'm a rheumatologist, and I swim in methotrexate all day and hydroxychloroquine. And one of my very favorite medicines is hydroxychloroquine. I think it should probably be in the water, but it's a very good, safe medicine. But You know, I practice in an area of New Orleans, of the country where I mentioned before, New Orleans, where we have very, very high cardiovascular disease risk profile. But also a colleague of mine who practices in the Netherlands, where they don't have such a profile, she has a similar take on using steroid-sparing agents. So when I see a patient, you know, when you see enough sarcoid, I think you get a feeling for who's going to progress based on how they present to you. And I almost immediately start methotrexate and plaquenil in combination, because my goal is, as Dr. Ravi had said earlier, is at all costs I want to avoid the complications that steroid brings with them. And glucocorticoids bring with it a number, and we understand that, and sometimes it's a very, very necessary part of treatment. But when it's possible, we really try to wean patients off of steroids. And I think, as Dr. Royal was saying, there's some hopefulness in the ACTHAR study to maybe perhaps glucocorticoid spare, but we don't really know the steroid side effect risk profile very well and how it compares, because it is actually stimulating body's steroids. So, but hopefully we'll get good data from that.
Thank you.
Thank you. Next question.
Hi, I have actually a couple questions. One, do you know if there has been any studies done on occupations being involved with sarcoid? And also your take on treating sarcoid holistically.
I can certainly talk very generally about the occupationally related, because sarcoidosis is thought to have an environmental trigger. Clearly, there are some occupations that are that just by nature have some odd, things, antibodies in the air, antigens. So, they know that coal mining is one of them, and that there has been a very powerful study on the 9/11 first responders in terms of the diseases that 10 years afterwards they showed to have. I would, if I were you, I would just Google 9/11 study. But also, I know in National Jewish Health out in Denver, Dr. Lisa Meyer does quite a few studies around that as well. But I'll turn it over to the doctors.
When I showed the CT scans, I showed you that sarcoidosis is present predominantly in the upper part of the lungs. That tells us there could be some exposure. Because whenever you have exposures, like even some of the smoking-related diseases are upper lobe predominant. But nobody has nailed it through the big studies yet. But the 9/11 first responder studies, they said it's sarcoid-like granulomatous disease, and they did not have involvement of any other organ. And I talked to you about beryllium earlier. A lot of people, when they see beryllium, they diagnose sarcoidosis, and they don't dig deep into the occupational history of working in an airline industry. So, and also the next point is sarcoidosis is by exclusion. If you have coal mine-induced lung disease, it is not sarcoid. It is coal mine-induced lung disease, and so nobody has concluded any association with particular occupation. They studied the U.S. military studied in Navy recruits in the past. If you can, and again, the conclusion was we have insufficient evidence to link it. Some healthcare workers were thought to be having occupational risk of developing sarcoidosis. That's also not proven beyond anything. About holistic treatment, I think you. Okay.
Well, I really don't. I really don't know an awful lot about holistic treatment other than mindfulness. And I think it would be a good idea if we looked at some of the studies that were done, because they're in another disease that I work in, scleroderma. I actually came upon because one of my dear colleagues, his wife, developed that illness, and he brought to me, just as we were working together at the VA, all these studies on that were fairly well done on various holistic therapeutics. And I'm like, oh my gosh, what kind of a doctor am I? I don't know any of this stuff. But there, you know, in terms of inflammation, do you guys know about any studies with curcumin that's being done? I know that it was being looked at in rheumatoid arthritis. I don't think in sarcoid. But
I'm not aware of that, but you know, when it comes to these autoimmune diseases like sarcoid, there's a lot of interest in what people are calling modifiable risk factors. So people are starting to see where this sort of gene-environment interaction is starting to inform as to what it is in the environment that can trigger the inflammation. So there's cigarette smoking, which is obvious, but people are starting to see where. So we actually have a study looking at cigarette smoke exposure and brain inflammation. And it turns out in our studies, we're seeing that a person doesn't even have to be the smoker, but be where smoke has been. And what we're looking at, we're seeing lots of inflammation. And clearly that's not good for sarcoidosis. So starting to learn a lot about diet that can control inflammation, not just what you eat, but the sort of bacteria that in your gut even. And people are interested in, you know, there's been this interest in whether infections can be behind sarcoidosis. And, you know, we test for a lot of infections, but we're not able to test for everything. And these days there are some methods for really taking a look at just about everything on the planet in a very quick and easy way to see if maybe there is an infection that just wasn't detected before. So those sorts of things could help us out. And in a way it falls under that holistic when you talk about diet and behavior and all those sorts of things, which can explain why certain families who have a genetic disposition, or people of a certain race, or people who live in a certain part of the country. Keep going back to the MS example, where people who live in the northern areas of the country and the world tend to be at higher risk for MS and populations who are from those areas. Well, it turns out now we know vitamin D is important for causing changes in the immune system so that you're less likely to develop MS. And of course, there's more sunlight in the southern parts of the country and the world. And people have certain diet habits that allow them to have more vitamin D in their body. So I think we have a lot to learn, and what the foundation is doing by getting people to sign up, provide information about themselves, and to make themselves available for studies is really going to have a huge impact.
Thank you.
Thank you. Next question.
Hi, I been recently diagnosed with sarcoid of the cervical spine. I was originally diagnosed in '69 with pulmonary sarcoid. It was back and forth in remission for years. However, at the same time, I was diagnosed with iritis. Later on, I became ill with chronic sinusitis, bronchitis. In '07, I came down with vertigo, acute vertigo, that I couldn't even be on hands and knees and crawl. I have what they call demyelination of the central nervous system. I'm retired military. I took an MRI to my PCP at VA because it suggested that I had neurosarcoid and asked him what they were going to do about it. So they went to DC and got permission for me to go to UT, University of Texas Northwest at Dallas. And I'm currently on CellCept and prednisone. I think I've heard or had all darn near every symptom with people I'm hearing today. And I also started off with a murmur in '69 when I was diagnosed with the pulmonary sarcoid. But after about 10 years, it sort of like dissipated. My question now is, will that CellCept cause my skin pigmentation to lighten? Because that's what I'm seeing.
Well, I have not seen that happen, and I use it all the time, this CellCept, and in African American patients, and I have not seen that. You can find skin changes with the hydroxychloroquine. Have you guys experienced any CellCept skin changes?
One other quick thing too. I was given, because when I was in California, I was diagnosed with peripheral neuropathy, and also it's one other thing too, occipital neuralgia. And at the same time, she started giving me corticosteroids for the peripheral neuropathy in my arm, and I stopped because, again, I had that same problem. And, you know, I'm used to this.
You know, my experience in treating neurosarcoidosis is to treat it with what works. I really can't sit down and say, this is what you give and this is what you expect. So I'm glad to hear that the combination that you're on works. My experience is that, you know, if you took away the side effects from steroids, neurosarcoid would probably be cured. Everybody I ever treat responds, but eventually the side effects just catch up with them. So now, when you talk about the skin lightening, are you having patches of skin lightening, or?
It was on the elbows.
Yeah.
She was giving me injections in the elbows and up around my wrist. But as it's starting out on my fingers now,
Yeah.
it seems like it's gradually moving up.
Yeah. So something to discuss with your doctor. I think again, you know, we talked about how the anti-TNF can sort of shift the immune system so that it's going from Th1 way over to Th2. Well, a big Th2 is antibodies, where your body starts making antibodies against itself. So you can actually develop an autoimmune disease while you're treating an autoimmune disease. And you may have heard of vitiligo, where you make antibodies against, you know, the melanin-forming cells. So something you want to discuss so that it's possible, you just want to check to see if you're developing one of those types of side effects from the medication that you're on, and maybe a good idea to talk about something else.
Next question.
I've actually got two questions. Most of the people here are from or have their significant other with them. And I was wondering if there is any incidence of familiar, you know, anybody in the family group developing sarcoidosis. And the second thing was, since he mentioned he was in the military and you mentioned beryllium, has sarcoidosis had a trigger been connected to hexavalent chromium?
What's the last word you said? Chromium?
Yeah, hexavalent chromium. It would be like zinc chromate paint, which is common in the military.
Okay. So I'll take the second first. If you have any suspicion of occupational disease that causes granuloma, we can do a blood test called lymphocyte transformation test for beryllium, and that needs to be done. And when we do the bronchoscopy, we can also do we collect that fluid called bronchoalveolar lavage. That means we instill normal saline and we get it back, and we can also check that lymphocyte transformation test for beryllium. and we can confirm it. And usually whenever you have beryllium, you do not have extra pulmonary involvement. It's only involves lungs, that's one. About the familial sarcoidosis, they had done a study called access study in the past, and there is high likelihood of developing sarcoidosis in family members, blood relatives. That's usually more in siblings than in parents. So that's been established, and we had presenters showing HLA type involved in sarcoidosis. That tells you there is some genetic predisposition we mentioned. So yes, there is genetic predisposition for sarcoidosis, and there was a study done in the past showing some cluster of cases in the families.
Next question.
And you can
Katie,
Google
Nadia?
access study in sarcoidosis.
Yeah.
Hi. I was diagnosed last year with sarcoid in my heart, lymph nodes, and lungs, and eyes, and my skin. And I was on 60 milligrams of prednisone. Yes, thank you. and I've been off since July. And my eyes are coming back, and so is my skin. My question is, I know we never tried anything but prednisone, and that's what my doctor seemed like the protocol is going to be from now on. So this has been very informative. But my question is the eyes part of the neurosarcoidosis? And I've never, nothing like that has ever been mentioned. So that's my question.
So the eyes, certain parts of the eyes are a part of the nervous system. So the posterior structures, the nerve that goes to the back of the eye is actually a direct extension from the brain and considered a part of the central nervous system. But once you start getting into the eyeball and the structures more interior, and like with the lenses and that sort of thing, that's not part of the nervous system, but still susceptible to being attacked by sarcoidosis, and certainly important to treat effectively.
I agree with this. It's in my slide, but I did not highlight because I spoke only about lungs and the heart. Anterior uveitis, it's called, if it's anterior, that's treated with only topical steroids. But once it's posterior, it's considered as neurosarcoid, and it needs to be treated like such. And about the treatment thing I mentioned in my presentation, the thing is to maintain on a low dose, extremely low dose steroids or steroid sparing agents like hydroxychloroquine or methotrexate for a long time. I would consider keeping the patients with a neurocardiac sarcoid on medications for 3-5 years, but I want to keep it, but I monitor very closely for the adverse effects, but you had to monitor for the disease activity again. You have anything?
No, I'm in complete agreement with both comments. Yeah.
Okay.
Thank you. We have another
Next question.
Thank you. You had mentioned that there could be permanent nerve damage or pain from neurosarcoidosis. What do you say to doctors that are reluctant to prescribe pain medication for that type of pain, and even if it extends into other conditions besides neurosarcoidosis or sarcoidosis in general, if you have more than one thing wrong with you?
Pain can be, as you know, very difficult to treat. And many physicians don't have a great deal of experience at effectively treating pain. There are physicians who do, who make it their living to really do a good job.
If I can just add real quickly, I was referred to a pain management clinic, but they essentially just wanted me to do a test. They wanted me to do a clinical trial where I couldn't ask any questions about what the pain cocktail was, as they called it. And that's kind of where my dead end stopped. And I really haven't had any sort of treatment or anything beyond that. I've got herniated discs from a car wreck and pulmonary from a biopsy in my lungs. They found them both top and bottom. So I'm not sure what else is going on, but I'm just kind of, hesitant to go back to my own doctor and wondering, are there any doctors around this area that anyone would suggest? Or not, Yeah. Open floor.
Like you mentioned earlier, if one place doesn't work, you should look for other pain management clinics. Generally, doctors these days, they do not prescribe narcotics, primary care or pulmonary. I don't even prescribe any pain medication. So it all comes from the pain management clinic. And if one doesn't work, you need to go to the different clinic.
And I think if I can add that some of the resources that are available for sarcoidosis patients on our website allow you to communicate with other patients about questions just like this. Number one, we do have a physician's directory. It's not as robust as it needs to be, but where you could, it certainly needs to have more filters, et cetera, and we're working on that. But the second thing is that there is and I'll be talking about this later, but there's an online support community, and it's the Inspire, and I'll give you the link and everything, but and many times patients will go on there and literally say, hey, this is where I live. Does anybody have a good, SARC doctor or pain management clinic or whatever? And it's so nice because it's real people, but it's virtual. So
Right. I haven't tried your forum, but I have been on other forums, and I wasn't able to find anything in Missouri. My insurance limits me to be in Missouri.
And that's another issue then, because then you further get down to issues like
And
that.
just one further thing, are you related or in contact with the Bernie Mac Foundation at all?
Yes, we are, yeah, and they're a great foundation. They support primarily University of Illinois at Chicago, but we do work with them as well.
Thank you.
So one of the issues when it comes to pain is that in your case, it sounds like you have several different reasons why you have pain, each which should be treated in its own right in a specific way. And then in addition to the fact that the pain medicines don't work as well once you increase the dose, you can actually develop pain because you're at the high dose, what's so-called overuse, headache and other pain syndromes. So it gets to be very tricky, and it's a real process working through those issues with physicians so that you can get the relief that you want.
Next, we have time for a few more questions.
Hi, I wanted to ask about the use of steroids when you have osteoporosis. In the past 3 months, I've had 5 broken ribs just from hugging or lifting. And
I will answer that question before I go to the airport. So the American College of Rheumatology has an algorithm for the use of steroids and how to protect further bone loss in osteopenia and osteoporosis. So those guidelines are available, and they're available freely on the web. And you can go to rheumatology.org, and or you could just Google ACR guidelines for steroids and osteoporosis. But that often involves the co-treatment or the co-prophylaxis, depending on how much bone loss you have, with a medication like alendronate or similar medications. Yes, but it should be given a good deal of attention, yes.
Okay, and I think,
Thank you. Go ahead. I was just saying goodbye to the doctor, so sorry.
I kind of have 2 questions. I was diagnosed with neurosarcoidosis, and it's only in my brain. I don't have it anywhere else. my doctor decided not to do a biopsy. He's ruled out everything else, he said, so he has said it's neurosarcoidosis. And so my first question is that okay? I mean, can I say I have neurosarcoidosis if he doesn't want to do the brain biopsy? And second, I've been reading a lot about, the mortality rate. I have a family, I've got 3 kids and a husband whom I love very much. And I know that everywhere I've looked, it just says that if there's complications. Well, I just kind of want to know, it's in my brainstem, it's in my pituitary gland. What are the complications, and what should I prepare myself for?
Okay, well, it sounds like he made the diagnosis based on some of those locations, with the sarcoid being in the pituitary gland, which is a very classic location for getting it. With what do you have to look forward to as far as what sort of problems you may develop? I'll have to tell you this, but when it comes to the nervous system, the areas that's involved are going to define what sort of at least symptoms and disabilities you might develop, if not controlled. Without knowing how well you're being controlled, one can shrink those areas of involved, that is the masses, I would call them. I would probably try to talk you into having a biopsy, a meningeal biopsy. And I'm saying that without knowing what your case is. It's very difficult to biopsy the brainstem. I wouldn't suggest that. Wouldn't suggest biopsying the pituitary gland. That's where the hormones are, the stimulation of hormone production occurs, and control of some very vital functions in the body, like blood pressure and heart beating and all sorts of things. So, one can, and again, I'm speaking without really knowing details, one can go into a biopsy procedure knowing that there is a chance that you won't learn anything, but there's also a chance that one might get just the information you need to commit to a certain diagnosis, because it is a lifelong disease that we're talking about here. And one difficulty that can arise is years later, if things start looking a little questionable, and you start wondering, gee, did I make that right decision? You just want to be able to commit and really push hard with the information that you get. So that's the way I look at it. Again, I don't know all the details. There may be a very good reason why, but a blind biopsy. So I showed you the result of a so-called conjunctival biopsy, where the sclera, the white of the eye, was biopsied in a person. Very often when you decide to do that, it's because you look at a person's eye with high magnification, and you see an abnormality that looks like maybe there's something going on there. You biopsy, you see it. In a certain percentage of people, you do a blind biopsy. You just take a shot, and it's in a small percentage. It is a small percentage. You may get a positive result. One can do that with the meninges. One can even do that with the eye. Again, if you have questions, talking to other doctors about some ideas as to how to make the diagnosis may not be a bad idea. Would you ever do a sort of blind pulmonary procedure?
We sometimes attempt when just even if the radiology is not consistent with the sarcoid, just as a last resort, we do the blind biopsies. But did you have a high resolution CT scan of the chest? Plain chest X-ray may not be helpful sometimes. Yeah.
Is it clean?
It should be high resolution CT scan. Okay.
Okay, thank you. We have time for one more question, I think, or maybe we can squeeze two in, move fast. So excuse me if I'll have to cut you off because we're really pushing on time, but go ahead.
My husband has sarcoidosis and he was diagnosed in June, I believe. But I was just wondering if anyone else is having problem with their teeth, because the enamel on his teeth has crumbled and his teeth are breaking. But he also had cancer and went through all the cancer treatment back in 2005-07. So I don't know if maybe that is related to it, but we don't know what to do about his teeth.
So
You got something to say?
I have not come across any problem with the teeth unless it's the side effect of steroids, okay? And sometimes when you're on alendronate, and if you go for a dental treatment, you can have osteo means bone necrosis. Are you on alendronate, Fosamax? No? So it could be the side effect of the chemotherapy for, yeah. So he had radiation therapy? Yeah, I think it's probably radiation therapy induced stomatitis or mouth inflammation or something. Yeah.
I have the same problem. My dentist told me that I do performance in regular implantation that actually has citric acid. And if you don't brush your teeth after that, it's using the enamel.
Sure. That's different because there's a steroid inhalers. You can develop fungal disease in the mouth. That's why you need to rinse mouth and brush your teeth after that.
I have to have special quiet toothpaste with
Sure. So that could be radiation therapy induced. You know, I don't know enough about radiation therapy for the mouth. Okay.
Great.
If I hope you don't mind my making a comment about the fact that you had the chemotherapy and later developed sarcoidosis. We talk a lot about how steroids can cause these side effects, and they come on when you treat with high doses to try to suppress sarcoidosis. And one of the complications of steroid treatment is something called Cushing's disease. And Cushing's disease, classically, I think I mentioned that occurred in people who formed a tumor in the brain that overproduced ACTH. And it turns out in some of those patients, when you took that tumor out and the steroid that they were producing dropped to a low level, they developed sarcoidosis, sort of as a rebound from removing very potent immunosuppression. And that's been observed to happen in some other conditions and disorders as well. So I wonder if that could be a link between your having sarcoid and having been potently immunosuppressed in the past.
I actually had dental issue with mine, and it was from medication. And I was so late, so I was chewing and teeth just started breaking off the teeth. And they called it shoulder. Like shoulder.
Sure.
SJ?
But it's not just the mouth, they have to do driving through the eye, skin, as well as fresh on the tongue. And that's from medication. So I'm on a medication called Pulmonary for the help produce saliva. So I take like a bird. You first take it there, and then my large layer, and then try out and then so the dentist prescribed two things, a higher dose of fluoride and a paste. That should use one in the brush and one throughout the day.
Great. Thank you. Go ahead. Yep.
Well, Sjogren's syndrome it's a specific autoimmune disease that you can have and not have. Theoretically, a person can have more than one autoimmune disease. But it's interesting, you mentioned that not making saliva. You need saliva. It lubricates, it protects. So if you're not doing that for whatever reason, that could put your teeth at risk. Sure.
All right, we have time for just one more question. I apologize, then we're going to move on to lunch. So, Nadia?
This should be a quick question, but a lot of people here are on steroids, and one of my doctors was having me take steroids, a dose every other day, he said, to decrease symptoms. And that's what I'm doing now in my maintenance. And does that work? I'm gonna get a second opinion, and maybe other people could benefit from that.
It definitely works. That's one of the ways you will maintain people on a low-dose steroids is giving it every other day. I have done it in my own patients. So keeping the patients on a very low dose long time is the trick in managing sarcoidosis effectively without causing adverse effects. Giving every other day is a reasonably acceptable regimen. Okay. People have done it even in the high dose too, but usually I do it for the lower dose. Okay.
Yeah, as you know, when you take steroids, you're suppressing your body's ability to make its own steroids. So if you stop them, you end up being low on steroids and can become very sick for that reason. So one reason for giving steroids every other day is to not take them as often, but not so often that your body ends up being deficient and you're getting ill because of that. If you just stop cold turkey today, by day after tomorrow you'd be pretty sick. Yeah. But taking a dose before that happens keeps you feeling well, keeps you on a low dose.
And one more comment to just back it up is, we may have treated sarcoidosis, but we may have created a condition of chronic adrenal gland suppression. If not for sarcoid, you may need the every other day steroids just to keep your adrenal function working. It's called a replacement dose. That's what the research is about. So we need to be aware of that one too. Okay?
Thank you.